Good morning, good afternoon, good evening, everyone. Thanks for joining us today for our webinar, Do You Think Accreditation Proves Your Site Practices MRI Safely? My name is Dan Kuzneski. I am Vice President of Global Marketing, and I would just like to start by telling you how excited we are to have you joining us today. From every corner of the world, we have about 1,000 people registered for today's session. Fantastic turnout. Thank you again for everyone dedicating an hour of your day today. Before we get into the presentation with Tobias Gilk, our featured speaker, I'd like to go over a couple of housekeeping items. For those of you who do not know who MetroSense is, we are the leading provider of advanced magnetic detection systems, and one of those key areas is providing those solutions within MRI suites, both in Zone 2 and in Zone 3 ahead of Zone 4. Through the use of our FarrowGuard screener and FarrowGuard Assure systems, we help to mitigate the risks of ferrous projectiles. For more information about MetroSense, you can visit us on our website at www.metrosense.com. Today's webinar will be recorded and it will be available on demand approximately 4 hours after the conclusion of the session today. And as well, today's session qualifies for 1 CE credit, and that will be issued within 24 hours. A certificate will be issued at the conclusion of today's session. You are required to be on the session for the duration in order to receive that certificate. Allow me a moment now to review the controls and functions on the screen in front of you. In the upper left is the media player. The media player will provide you with timed guidance for today's session. As a reminder, the session is scheduled for 1 hour. In the bottom left is a Q&A window. At the end of today's presentation, we will have a Q&A session. To submit a question, please enter it in this box and hit submit. Please submit your questions early and we will get to as many of them as we possibly can. In the center of the screen is your slides window. All visual aids that will be used today in the presentation will be displayed in this area. In the upper right is a resources window. This will contain resources referenced in Tobias's presentation from today, as well as additional resources as provided by MetroSense. You may download these at any time throughout today's presentation. In the bottom right is a speaker bio window. This window can be expanded to read the bio for Tobias Gilk. There are also social media links to connect with him on Twitter, Facebook, and LinkedIn. Lastly, on the bottom of the screen, you will see a group of icons. Each of these icons open or close any of the individual windows. If you would like to close a window, simply click on one of the icons. If you would like to bring it back up, simply click it again. So without further ado, I am now going to turn it over to our speaker, Tobias Gilk, to get us started with today's presentation. Toby, I'll hand it over to you.
Thank you very much, Dan, and welcome to Do You Think Accreditation Proves Your Site Practices MRI Safely? A little bit more about me as your presenter. I am an architect by training. My day job is with radiology planning, RAD planning. One of the founding board members of the ABMRS, the American Board of Magnetic Resonance Safety. Was a special consultant and a member of the ACR's MRI Safety Committee 2 times previous, contributing to the 2007 guidance document and the 2020 manual on MR safety. Founder of Gilk Radiology Consultants, and through GRC, ongoing consultant to MetroSense. When I give talks about MRI safety topics, I try always to include the disclaimer. Because I'm a board member and a member of the exam specification committees for the MRMD, MRSO, and MRSE examinations, I get to see the exam questions. So ABMRS allows us, encourages us to actually lecture on MRI safety, but not on specific exam question material. So, lest you think any of today's conversation is specific to ABMRS exam material, it's not. We're going to be talking about general MRI safety concepts and principles. So with that, I've kind of broken the subjects down into 5 sort of bullet-pointed areas. We're going to touch on what accreditation strives to do generally, accreditation's promise of safety. We're going to look at how patients get injured in MRI, because we are going to measure how individual accreditation orgs do or don't effectively prevent the most frequently recurring forms of injury in MRI. And we're going to close out with the question of, is there anything else we could or should be doing? So, with that, what does accreditation do? What is its objective? Ultimately, all accreditation regimes seek to promise 2 things, or seek to assure 2 things: quality and safety. In the United States, there are what are called deemed accreditation organizations, and these are the accreditation organizations you've heard of many times before, and they are essentially sanctioned by CMS, the Center for Medicare and Medicaid Services. Essentially, if you, as a hospital, as an imaging center, want to get reimbursed for the care of a Medicare and Medicaid patient, that facility has to be accredited by one of the CMS-approved accreditation organizations, or you don't get paid. So the net effect of this is there are about 9 out of 10 hospitals in the United States have accreditation for CMS reimbursement. I couldn't find numbers for outpatient imaging, but I figure it's got to be fairly similar. Which brings us to our first audience participation question. Which accreditation or accreditations does your site have? So this is a select all that apply. Click the radio buttons on the left-hand side, and then once you have made your selection or selections, hit the submit button down at the bottom. I'll give you just a few minutes, few seconds, really, to make your selections. And we will be moving on in 5, 4, 3, 2, 1. All right, here we go. So, accreditation promises safety, right? So how is that working out for MRI? Well, we have sources of information we can track. So this chart, if you've seen me speak before, you may have seen versions of this chart. What we're looking at right now, the blue line represents MRI procedure volume growth. So taking the year 2000 as our starting point and just looking at how MRI procedure volume has changed over the years using the year 2000 as a baseline. And over time, from the year 2000 to the year 2019, MRI procedure growth grew at a fairly consistent 3 to 4% per year. In the year 2000, the beginning of COVID and the shutdowns, you see the massive sort of nosedive of the numbers there. If we did an equally good job managing MRI adverse events, if we plotted change in adverse events over time, it would be right on top of the blue line. If we were getting better, if we were improving adverse event rates, it would be below the blue line. However, what is actually happening is this. over time, the growth in adverse events is, MRI classified adverse events, is somewhere on the order of 2.5 to 3 times, if we ignore that inexplicable camel hump in the middle of the red line data. If we just take that out and we look at the stuff before and the stuff after, we're looking at 2.5, 3 times rate of growth, meaning whatever the rate of growth is for MRI procedure volume, the growth in adverse events is 2.5 to 3 times that. While the number of adverse events is still small in the grand scheme of things, this trajectory of growth, this 2 to 3 times growth rate for adverse events over procedure volume is unsustainable. Yes, we could continue to do it for quite some time, but unsustainable in the sense that it goes against the very promise of MRI safety. We are doing worse over time, and that should frighten all of us. It's important to note that in the data that I was just showing you, that doesn't include MRI's negative interactions with implants and devices. So if an MRI caused a pacemaker to malfunction or caused an implanted medication pump to over-deliver or fail to deliver indicated dosage, that data is not captured in the red line chart. So the thing that we spend the most time on a per patient basis for MRI safety, implant devices, that data isn't even captured in the MRI classified data from the FDA. So all of that is in addition to the red line data that I showed you. And it wasn't until not that terribly long ago that MRI manufacturers essentially forbade us from imaging patients who had implants and devices. So my expectation is over time, the proportion of MRI patients that have implants, devices, other complications or contraindications, that proportion of our total patient volume has gone up, meaning risks have increased. And here we're looking back at your answers from just a few moments ago about which accreditation organization or organizations govern MRI safety at your facility. And thank you very much for sharing that information with us. That's really interesting. Okay. So these are your answers to the first question. Let's ask you another question. How much do your accreditation standards, the ones you just identified, the accreditation organization, how much do they assure safety in MRI? Now, unlike last one, which was you can select multiple answers, this one you need to give us your one best answer. Do your accreditation organization's MRI safety standards, are they essential to MRI safety at your site? They help a bit. You know, they're constructive, but they're not the be-all, end-all. Or you're kidding me, right? They're no help at all. They're just checkbox items. We have to do them, but materially they don't improve MRI safety. Pick your answer and hit the submit button, and we are moving on in 3, 2, 1. All right. So, if we're going to make statements about safety, I think it's important that we have sort of a common understanding of what safety means. And in my opinion, and I think this was probably a pretty safe assumption that this should be a common foundational definition of safety, is we don't hurt people, right? So if we're going to look at MRI safety standards, the standards that help us prevent people from getting hurt, we should have a good understanding of how patients actually get hurt in the MRI environment. So why don't we look at that? One of the reasons that it's kind of difficult to look at is this information is not widely published. What you're looking at on the screen is a screen capture. The URL is at the bottom of the screen. This is also in the resources link here on the webinar. But this is a an infographic that describes MRI injury accidents, again, FDA classified MRI injury accidents, and how they break down. And then we're going to look at some information about how these injury accidents can be effectively prevented. So first thing to note is that injury accidents in MRI, 95% of MRI classified, again, US FDA, MRI classified injury accidents fall into three categories: burns, projectiles, and hearing damage. Let's take a look at each of those three injury accident types and test whether existing best practices could be effective in stopping those injury accidents from occurring. Let's with projectiles. So this data that I developed for MetroSense is actually based on a research project that I did with Dr. Emmanuel Canal. We presented at the 2012 RSNA meeting. This version has more contemporary data, but we use the exact same methodology, the exact same tests. So we took from existing best practice literature, at the time, the ACR guidance document 2013, and we picked out three projectile accident preventions, and we tested the narrative of these injury accidents against these best practice preventative steps to see if, would one or more of these likely have prevented this accident from occurring. For projectiles, the three preventions that we chose from the ACR guidance document were the use of the ACR 4 zone, access controls and supervision, the use of ferromagnetic detection, and the use of conspicuous labeling of MR conditionality of objects, materials, devices. When we looked at all of the projectile accidents for a 2-year period, it appeared as though one or more of these preventions likely would have stopped 69% of the projectile injury accidents that were reported to the US FDA. 69%. The curious thing is that the 31% that this wouldn't have prevented, those were almost all, actually I believe they were all, service personnel, people who should know better working around the MRI equipment, that probably would have ignored these preventions anyway. So if we were looking just at a clinical setting, this would have had 100% effectiveness. What about burn injuries? Again, taking the ACR guidance document, and we chose these three preventions: padding or air gap between the patient and the transmitting RF element, removal of electrically conductive materials and or insulation of any that need to remain, such as ECG leads for patient monitoring, and number 3, prevention of large caliber body loops through patient positioning and padding. When we looked at the burn event, the burn injury accidents in the FDA database, and we compared those narratives against these three protections, 94% of those burn injuries could have been prevented with these three best practices. 94%. That's pretty remarkable. The last, or the third most frequently reported injury in the FDA database classified as MRI is hearing injury. And the 2013 ACR guidance document really only had one prevention identified, and that is to provide your patients with hearing protection. The challenge is that 89% of the reported hearing injuries in the FDA database, the patient was at least minimally provided hearing protection. They chose not to use it. They used it incorrectly, and it didn't provide the benefit that we hoped. So 11% prevention would be better than where we are now, but it's sort of a drop in the bucket. So when Dr. Canal and I did this project in 2012, we actually came up with a couple of additional recommendations. to verify fit and function of the hearing protection, and then also to have available alternative means of hearing protection, such that if a patient can't or won't use a compressible foam earplug, you have a plan B available for that patient. If we look at those preventions, the one ACR prevention for hearing protection, ignoring the two that Dr. Canal and I came up with, those would have prevented 74% of the injury accidents that we looked at. 74%. And if 74% is good, 80% is better. 80% is what it was in clinical situations if we throw out the service personnel projectile accidents. 80% reduction in injury accidents. That has got to be pretty significant. So, I asked you the question, how much do your accreditation standards assure MRI safety? Essential? Meh. You're kidding, right? All right. Some of you people are seriously cynical, and maybe that's deserved. We're actually going to touch on that here in just a second. But first, I'm going to ask you the third audience participation question. So, if you felt as though your accreditation was not much help, what is it that you think does help? And even if you feel as though your accreditation standards are helpful, what else is helpful? Or what is most helpful besides that? Is it your hospital-specific policies? Or nobody else really helps us. It's all on us. Or Medicare, Medicaid, or insurer, payor standards. Those keep us safe. Pick your best option. And we're moving on in 3, 2, 1. Don't forget to hit submit. So I'm going to breeze through these fairly quickly. How do accreditation standards measure up? And we're going to look at the 3 injury types that we just went through in that infographic. And I'm going to compare the accreditation standards, the state language specific to MRI radiology for each of these 3 injury types. So the first injury type that we're looking at is projectile safety. And what you see here on the left column are 4 different accreditation organizations: Joint Commission, BNV Healthcare, the American College of Radiology, ACR, or IAC. And across the top, you see the 3 preventions that Dr. Canal and I initially came up with. In this case, requiring the use of the 4 zones, requiring the use of ferromagnetic detection, requiring conspicuous device labeling. So, how do you think your accreditation organization does on this score sheet? Do they have specific, explicit protections for each of the 3 things that we know are going to be remarkably effective in reducing projectile accidents? Well, here we have it. The empty spaces, the voids, because there isn't anything from those accrediting organizations. So our 3 prevention criteria, requiring the 4 zone, requiring ferromagnetic detection, requiring conspicuous device labeling. For accreditation organizations, 3 different performance criteria, so 12 possible yeses or nos, and we have 2 partial credits. So the Joint Commission, when it comes to requiring the 4 zones, Joint Commission diagnostic imaging standards have language that kind of describe zones 3 and 4. They don't actually use the term zones, despite the fact that that seems pretty well standardized elsewhere in the literature, not just in the ACR. So they describe zones 3 and 4, but they don't talk about zone 2 and zone 1. So that's legitimately a partial credit for Joint Commission for that one, but they don't require ferromagnetic detection. They don't require conspicuous device labeling. ACR invented the zones, right? And yet their accreditation criteria, there's a safety checklist, and the performance item on that safety checklist is, and I'm paraphrasing here, but it's something to the effect of signage and access controls as appropriate. But the ACR accreditation criteria don't define what minimum appropriate is. There is this implicit reference to the ACR manual, but in the site accreditation criteria, it doesn't actually say that. So that's a really generous partial credit for the ACR. And those are the only two that really kind of have much of anything. DNV and IAC get 3 zeros on their score sheet for projectile safety. But that's projectile safety. Let's take a look at RF burn safety, burn preventions or protections. And again, the same 4 accrediting organizations in the left column, and then across the top row, we have our 3 burn preventions. Padding between the patient and the RF transmit element, padding or an air gap, removing unnecessary electrical conductors, and providing MR conditional and insulation as appropriate for any electrical conductors that need to remain for the study. And the third one is preventing large caliber body loop, skin-to-skin contact. So I'll ask the same question I did last time, based on the accreditation or accreditations that you hold for your site. How many of these do you think are explicit criteria for MRI safety for your accreditation? Well, let's take a look. And here, for Joint Commission, again, I'm giving partial credit, and I'm feeling really generous about this partial credit. Padding between the patient and the RF transmit source and protecting large caliber body loops. Joint Commission doesn't, their diagnostic imaging standard doesn't actually say to do this. So I'm really being very generous here. What they do say in the diagnostic imaging standard is that it is a required element of MR technologist training annually to be trained on patient positioning and burns. It doesn't say you actually have to do anything in practice with respect to patient care, but it does say that this training has to exist. So because that's patient positioning and that's not material in the bore along with the patient, I don't give them credit for removing electrical conductors. Again, I am trying desperately to find things to view these in a positive light, but they're not making it easy. And then DNV Healthcare, ACR, and IAC, again, complete strikeouts on those. ACR, they require policies on burn prevention. But again, they don't require any practice. They don't require that anybody actually be specifically trained on those things. So it's a blurry line as to where you give partial credit. If the goal is to prescribe specific concrete actions that prevent harm, really I shouldn't give anybody any partial credit on this. Because having a policy or implementing training when the practice of the specific prevention is really not required. But again, I'm trying to be generous here. So this is RF burn protections or preventions. What about hearing protection? And again, I'll ask you to think about your existing accreditation criteria and what is or isn't there for hearing protection. As before, the same 4 accreditation organizations in the left-hand column, and our 3 preventions are requiring hearing protection, verifying hearing protection fit and function, and providing alternative means of hearing protection for those patients who can't or won't use compressible foam in the ear plugs. So where do you think your accreditation organization falls? 0, 1, 2, or all 3 of these criteria? Not good, as with the previous 2. And again, I'm desperately trying to give partial credit here. Joint Commission requires training for MR technologists on hearing protection, but it doesn't require any policies for hearing protection. And there's no information about verifying fit and function. There's nothing in any of the major accreditation criteria about providing alternative means if in the ear hearing protection doesn't work. This is embarrassing, guys. These are the most frequent ways that patients get injured in MRI, and these are preventions that can be demonstrated to dramatically reduce the likelihood of these injuries, and yet they are not required elements in ostensibly MRI safety standards for patient care. So that brings us to essentially the summary scorecard. For the 9 protections, really, 7 from existing best practice documents, and then the additional 2 from Dr. Kanal and myself with respect to hearing protection. So if you want to change the denominator on this from 9 best practices to 7, that's fine. Joint Commission, I give partial credit for 4. Really, if we want to be sincere about this, it's probably 1 partial credit, and the other 3 I'm really stretching because it's training that constitute the other 3. It's not requisite minimum practice. So depending on whether you want to be generous with me, it's 1 out of 9 or 4 out of 9. Or if you want to be really generous and essentially change the denominator and say, we're only going to look at 7 as published best practices from the ACR guidance document. So it's either 1 out of 7 if you agree with me that training does not dictate specific practice. 4 out of 7 if you're willing to accept that training does. DMV healthcare gets a goose egg. Doesn't matter what denominator, whether you're using 7 best practices or 9 best practices, they get 0. ACR, I give them partial credit because they require a policy on one of these issues. But again, requiring the existence of a policy when you don't require what the substantive content of that policy is, that is super generous partial credit. So I know I've got it on the slide here, but I'm actually tempted to essentially say that this is, in honesty, they're a 0 over 9 or 0 over 7. Same with the IAC. These are accreditation organizations that in the first 2, Joint Commission and DNV, the parentheses at the end of it, H, those are hospital accreditation or enterprise level accreditation organizations. You'll see the OP in parentheses behind ACR and IAC. And that's because those are modality-specific accreditation organizations. They accredit the MRI machine, the CT machine, and the practices that go along with it. And so those are predominantly outpatient imaging accreditation. Now, you can absolutely be in a hospital that has both Joint Commission or DNV and ACR or IAC. And ACR does accredit a lot of hospital MRIs, but they're predominantly an outpatient imaging accreditation organization, at least within the context of accreditation qualified for reimbursement in the United States. The other thing that I want to make sure that I mention, because I know we've got folks attending the webinar from outside the United States, the criteria I'm giving you here for Joint Commission is for Joint Commission of North America. Joint Commission International, or JCI accreditation, quite honestly, they would fall below DNV or IAC in terms of their MRI-specific preventions. JCI, Joint Commission International, they got nothing with respect to explicit preventions or protections against these most frequent sources of MRI patient harm. So, how do our standards measure up? Not well. This slide really sort of captures it. Despite the fact that all accreditation organizations promise safety, it's quality and safety. It's the bedrock promise of an accreditation organization. When it comes to MRI, even when that accreditation is MRI modality specific, as is the case with IAC and ACR, even when it's MRI modality specific, the minimum explicit performance criteria outlined in the accreditation standards, the thou shalt statements in black and white, they don't actually prevent harm. And remember my assertion, and I hope you agree with me, that the prevention of harm, the prevention of injury, really should be the absolute minimum standard that we use to assess safety. So they promise quality and safety, and yet, with respect to this minimum, baseline, everybody should agree on it, measurement of what constitutes safety, prevention of injury, prevention of harm, the accreditation criteria don't actually do that. And that should bug all of us more than a little. So what did you think? If accreditation isn't the be-all, end-all, who else do we turn to? And okay, all right. Well, so I can see, I probably should have phrased this a little bit differently. It's all on us and hospital policies. What I meant was hospital policy is sort of enterprise level, overall policies for the entire facility. But this is interesting. Thank you guys for responding to those. So here we come to the part where we talk about what could we do, what should we do in terms of making sure that we're preventing potential harm in the MRI environment. It really is, it is up to the individual site. And in contrast to my not very clearly worded question in the Q&A, the audience participation, I really think that this needs to be at the level of the radiology department. By all means, if you can get it, do get it, institutional enterprise level support from your quality and safety office or what have you. But it comes down to the individual site. It comes down to carefully thoroughly crafted set of MRI safety policies and procedures. It comes down to having individuals in roles of responsibility, roles of authority, such as MRMD, MRSO, MRSE, individual roles with responsibility and authority that govern the implementation of MRI safety best practices. So if it's down to us, how do we check to see if we're doing what we can do, what we should do? So the first thing that I would suggest is take a good hard look at your policies and procedures for MRI safety. Depending on the site, they may have been collecting dust for quite some period of time. You may have made changes in your clinical practice. You might be doing stroke patients. You might be doing ICU patients. You might be doing anesthesia patients that you weren't doing 5 years ago, the last time somebody looked at your MRI safety policies and procedures. If your clinical practice, your hardware, your staffing have changed, then you really need your policies and procedures to accurately reflect that change and, what patients you're seeing and what you're doing to them, what scanners you're operating, who your staff is. So compare your policies and procedures to the way you practice today. Make sure that for the clinical policies, things that have to do with the safety of the delivery of patient care, make sure that those elements are reviewed and endorsed by whoever the supervising physician is for the MRI service. Ideally, this would be a designated MRMD, an MR medical director. When it comes to operational policies, what sequences we're going to do things, how we're going to staff, here we're getting into gray areas because we're crossing over between the safety of the clinical service and the operational details of the clinical service. But you want to make sure that, again, the radiology manager is episodically, periodically reviewing policies and procedures to make sure your policies actually reflect what you're doing, what you're delivering in terms of patient care. My recommendation is that whoever the clinical director of MR and the operational manager of MR, they should each review and sign off on policies and procedures for MRI safety at least once a year. And here we get to another element, your org chart. Who's responsible for MRI safety? Do you have a designated appointed MRMD, MRSO, and MRSE? Having appointed individuals who have responsibility and authority for decisions related to patient care is vital. If you work at a facility with nukes, a hot lab, your radioactive materials RAM license in the United States would get pulled so fast your head would spin if you didn't have an RSO appointed for the facility, or if your RSO left and you didn't bother replacing them for several months, you would lose your radioactive materials license. Why? Because the NRC recognizes that it is essential for safety of radioisotopes that there is an individual with responsibility and authority over practices at the local institution. We should be taking a page out of their book and making sure that we have comparable, similar structures appropriate to MRI for MRI safety. So find people to designate and appoint to these roles. And if you don't have MRMD, MRSO, MRSE defined in your policies and procedures, then this dovetails very nicely back to the previous slides. Make sure your policies and procedures reflect the way you actually operate. again, a parallel to ionizing radiation safety. Consider whether you want to have an MRI safety committee. I recommend it. I recommend that you take as a minimum sort of the model of an ionizing radiation safety committee, that it should meet quarterly, that you should set and measure performance improvement goals. How are you doing? How do you want to be doing? How do you measure performance in terms of safety? One of the reasons that I advocate for MRI safety committees is in a bureaucratic organization like many hospitals are, it's easier to get institutional support from, Vice President of Quality and Safety for a committee, for a structure, as opposed to an individual. So it may be more easy, you may be more successful getting institutional support with a committee than with just an individual appointed to a role. So with that, thank you very much. There is so much more that we could have gotten into with this. This is really sort of a quick overview, but I hope that it has provided you with some really valuable takeaway points. And with that, Dan, I want to turn over whatever time we have left for questions. How are we doing on time, Dan?
Thanks, Toby. We're doing great on time. We have about 15 minutes for questions. Thank you to everyone that has submitted a question, and if you still have any, please go ahead and submit those into the chat window. Let me start with the first question. Toby, does the camel hump in the adverse events chart correspond to easier ways of reporting adverse events?
That's a really good question, and I wish I had an answer to what the origin is. I feel pretty confident that the origin of that unusual peak in 2008 to 2012, that time frame in that chart that I showed, I'm pretty confident that it has nothing to do with it being easier to report adverse events. The FDA has been pretty consistent about not making it very easy to report adverse events. There have been improvements to the system, but the default way to report a device-specific adverse event is for you, the provider, to call up the manufacturer. So when we're talking MRI, you're calling up your GEs, your Philipses, your Siemenses, your Canons, and you're telling them, hey, we had an adverse event. And then that manufacturer reports it to the FDA. That default process really has not changed, period, end of statement, over the time frame that we were looking at. So no, I don't think it's because reporting became easier. I think it's been kind of bureaucratic and not terribly straightforward in general. And even if we thought that it had become easier, why then did it drop down after the 4 or 5 year period where we saw those really high numbers? Was it easy and then they made it difficult again? To be honest, I'm at a loss for why there were several years in there with significantly higher reporting numbers. Maybe digging deeper into the data might give us some indications, but for now, I'm kind of at a loss.
Okay, great. We have another question here. So you talked a little bit earlier about some infographic charts from 2012 to 2013, but do you believe the 2020 ACR document covers more information on these items than you are addressing here?
So yes, the fact that the when we did that evaluation, we were looking at the 2013 ACR guidance document. In no way should that be construed as saying the 2013 edition is better than the 2020 edition. 2020 edition is better. But when we did that evaluation, the 2020 edition hadn't been published yet. And so we were using what at the time was the most current and up-to-date version of the MRI safety standard from the ACR. So by all means, today, if we were repeating that analysis, I would use the 2020 manual. But at the time that we did it, 2013 was the premier, most up-to-date version.
Got it. Thank you. Next question. When designing an MRI safety program, what are the most important contents that you believe need to be incorporated in the structure of this program?
That's a great question. We could probably do an entire webinar just on that. In my opinion, I think the most important elements are individual responsibility and authority. So typically that would be sort of a designated MRMD, MRSO, MRSE, people who have both the responsibility individually to make sure that safety best practices are followed at the site, and also the authority to take action and make changes if they see something that is problematic. Going hand in glove with individuals, charged with responsibility and authority is the existence of really good policies and procedures to govern safe MR patient care. I see a lot of policies and procedures that are kind of slapped together because, our accreditation standard says we got to have policies and procedures. In my opinion, policies and procedures should really be dummies guides. You should be able to sit a brand new hire down with your policy and procedure manual and say, hey, please read through this and identify if you have any questions or concerns about it, because we're going to expect you as an employee of this hospital, this imaging center, to follow these policies and procedures when it comes to the care of MRI patients. If pick a patient about whom there was some question or concern that came through your facility recently. They had an implant or device or unidentified shrapnel or foreign body. Now go to your policies and procedures and follow explicitly what's written in your policies and procedures. Would those policies, would they have directed you to the same decision that you ultimately came to regarding the care of that patient? It's not going to work in 100% of the cases, but it should work in 70, 80, 90% of the cases. That your policies and procedures are essentially algorithmic decision assistance tools that bring you to the appropriate patient care decision. If they're not doing that for you, in my opinion, you're not using your policies and procedures to their fullest extent. So those are really my two top priorities for an MRI safety program. Individuals with responsibility and authority, and a very effective, comprehensive set of policies and procedures.
Great. Thank you, Toby. Another great follow-up question. Do you think that the events have increased or just the reporting culture?
So if we were doing, if adverse events were remaining constant and the growth in the numbers was because we were getting better about reporting them, then in 2000, when we saw really a catastrophic fall off of imaging numbers because of COVID and shutdowns, in the year 2020, we saw a 35% drop in MRI procedure volume. If we were doing better over time reporting adverse events, we would expect the reduction in adverse event reports to be smaller than the reduction in imaging volume. But the opposite was true. There was actually a 38% or 3% greater reduction in adverse event reports in the year 2020 than reduction in procedure volume. If we were doing better reporting adverse events, if they're consistent across time and we are over time doing better reporting, then 2020 is sort of a natural experiment because of the craziness introduced from COVID. We would expect to see different results. There are a lot of people who argue that the reason we're seeing numbers increase is better reporting, but the one chance that we've really had to kind of test that with the 2020 data suggests that no, that's not what's happening at all. Now, it's only 1 year. It doesn't disprove the theory, but there really isn't any evidence that supports the notion that we're doing better at reporting today than we were 10 years ago.
Great, thank you. We have time for a couple more questions. Here's another one. While I totally support Joint Commission and ACR, I'm at a loss at how to encourage my individual technologists because there's lots of pressure from an administration to do more exams in a shorter period of time. Do you have any suggestions for me?
That's a tricky question. I think that we've seen MRI technology, improve pretty dramatically. The number of images in a single MR study today, as opposed to 10 years ago, is significantly greater. We are collecting more diagnostic information in a single study today than 10 years ago, and certainly more than 20 years ago. Are we producing better diagnosis? The reason that it may seem like I'm sidestepping the question is ultimately MRI is about effective diagnosis. If we need to do more patients, then the core question should be, what do we need to do to maintain diagnostic quality? Are there extraneous studies or sequences or slices or levels of resolution above and beyond what we really need to perform effectively diagnostically that we could remove from a standard exam? Could we shorten the exam by making decisions about diagnostic benefit? If you don't essentially go back to the origins of why we're doing the MR study in the first place, and you don't think about re-engineering your process, if we're essentially supposed to take the same infrastructure, the same process, but we're supposed to do 40% more patients this year than last with the same resources, you are destined for failure. It is going to come crashing down around your ears, and God forbid we might wind up hurting somebody because of the rush to produce. We can produce more, but we have to re-engineer the process. And I think that's an imperative message at those sites where you're getting throughput pressures. That's an imperative message to take back to administration and get radiologist buy-in if you want to do something different.
Great, and time for one more question. It's kind of stated in a broad sense, but I'll put it at you, Toby. How do most view what the ACR says about FMD before Zone 4? It does not say it has to be at Zone 4. Neither does the 2018 hospital building document state FMD has to be at Zone 4 door. It is worded that it is recommended before Zone 4. So how do you suggest interpreting that or viewing that?
the great thing about the RF door into the magnet room, into zone 4, is ferromagnetic detection systems are trying to prevent or alert to the possibility of projectile accidents which happen inside the magnet room. The one place that we have assurances that everybody is going to pass through before they go to the magnet room is the door to the magnet room. In my opinion, projectile defense really should involve a gateway, a bottleneck, a portal, through which everybody who's going to go into the region where there is potential harm, we should put the ferromagnetic detection or part of the ferromagnetic detection regime at that point, which in 99.9% of the MR facilities is the magnet room door. That's not to say that that's the exclusive or only best place. In my opinion, when we're looking at deploying ferromagnetic detection, we should be looking at doorway systems for catching the medium and large stuff. And then we should also be looking at screener systems further upstream in a zone 2 environment to try and catch finer materials and at a more appropriate time in the process where we're going to present less disruption to patient throughput and patient care. So your site may have only one or the other of those, or may have neither. In my opinion, the best deployment of ferromagnetic detection systems is when you have both doorway systems at the magnet room entrance and upstream a patient or staff screening tool prior to them arriving at the doorway.
Very good. Thank you, Toby. And that is all the time we have today. So thank you, Toby, again for giving our presentation today and dedicating your time. For all of our attendees, thank you for giving us an hour out of your days. Just as a reminder, this webinar will be available on demand approximately 4 hours after today's live session. And your CE certificates will be sent in a link, also approximately 4 hours following today's presentation. I'd also like to invite everyone to join us on April 27th for another webinar titled MRI Suite Capital Planning Fundamentals. The registration for that webinar will open up today at www.metrosens.com. Thank you again, all. Enjoy the rest of your day.
Thank you.